Good morning, everybody. I'm just going to call the session open and welcome you very much to day 2 of our Hospice UK National Conference, Finding a Way Forward. Welcome to everybody here in Glasgow and welcome to everyone joining online. Just a couple of housekeeping points before I introduce our guest. Recordings of this session will be available online in around 10 days or so time. Whether you're here or watching online, you can ask Sam questions using the Slido app, and I think the details should be available up on the screen at intervals during the talk. If they're not, just collar one of the Hospice UK team if you have any issues using it. Please could you turn your phones to silent, and if you like someone's question, so what we tend to get with these plenary sessions is more questions than we can go to. But we have an algorithm, and the more people who like a question, the higher up it comes on the screens that Sam and I will see, so do feel free. So it gives me great pleasure to introduce Sam Royston, who is the Director of Research and Policy from Marie Curie. I just wanted to say something very brief about when we talk about the patient in end of life and children's hospice care. We talk about how important it is to have all parts of the system working well together for the best outcomes for the family. And we, as a sector, as a health and social care sector, we all get frustrated if we see different parts of the NHS or social care systems not working optimally together, and we can see the impact that has. And I also think that principle should guide our own accountability for the larger civil society organisations working in this basically under-resourced and under-covered end-of-life and palliative care space, to be working as collaboratively, as positively, and as effectively together as possible. So I would like, whether it's Marie Curie, Sue Ryder, Macmillan, or the independent hospice sector, all of us are working towards a really important goal, and I think must do so positively and collaboratively. And it therefore gives me great pleasure to welcome not just Sam, but to a veritable football club style number of Marie Curie participants at today's conference. Anyone from Marie Curie, could you raise your hand? I mean, it's half the audience at least. It's wonderful. So we're here to listen to Sam, who is Director of Research and Policy at Marie Curie. Since taking on the role, Marie Curie has successfully campaigned for the explicit legal requirement for palliative care services to be commissioned in every part of England, and initiated the UK Commission on Bereavement, an independent commission exploring changes needed to policy and practice to better support bereaved people. Following publication of groundbreaking new research identifying the number of people dying in poverty each year, Marie Curie also recently launched the Dying in Poverty campaign, which I personally think is absolutely brilliant and so impactful and hard-hitting and important, calling for key changes to ensure that nobody faces poverty at the end of their life. Sam himself was previously Policy Director at the Children's Society and is also a former chair of the End Child Poverty Coalition. He's the author of the book, Broken Benefits, What's Gone Wrong with Welfare Reform. So, Sam, welcome, and please go ahead. Yeah.
Toby, thank you very much indeed. And thank you for the invite to speak today. The long walk across to hopefully find a clicker. I was worried there wouldn't be one here, but there is, so that's good. Thank you for the invite to speak. And it's the Dying in Poverty campaign that I want to speak to you about this morning. But I want to start by telling you about Victor's story. Victor was diagnosed with stage 4 prostate cancer in 2019. And at the time, he had a very good job. He had a very good job. He worked for a large logistics company. He had a very decent salary. He had a company car. And after he was diagnosed, he went through chemotherapy. He was scheduled for an operation. He had to have part of his hip and femur removed. And then COVID hit in 2020. And Victor was the first one made redundant in the organisation. And he lost his job, he lost his decent salary, he lost his company car. He really didn't have much to fall back on. He ended up sleeping in another car. He unsurprisingly got heavily into debt, says he still has to borrow from loan sharks on occasion just to be able to eat. He said that quite frequently his food cupboards were bare. He wasn't eating, he wasn't feeding himself in a period where he's also living with terminal illness. And it's stories like Victor's story that makes it so important for us to think about poverty at the end of life. And I mean, this is not a problem which is unknown to Marie Curie. We're dealing with issues like this day to day. In fact, 65% of community nurses, this was end of last year, it's actually, I mean, the problems have grown greatly over the course of this year, but 65% Marie Curie community nurses said they believed they'd supported patients in the last year of life who are struggling to make ends meet financially. People struggling with the costs of fuel, food, housing, social activities, and many of the calls, and actually this number has gone up hugely over the course of this year. Calls to our helpline are about financial security issues, even without really advertising that that's something that we can advise or talk about. So we thought it was incredibly important that we did understand this issue better. I mean, astonishingly, we didn't even know, and we will come on to, we do now know, how many people face the end of their life while living in poverty at the start of this research. We didn't know how poverty risks at the end of life relate to age. Something which we'll come on to is incredibly important. And we didn't know whether there were particular groups within the population that were particularly likely to be affected by poverty at the end of life. So we sought to answer some of these questions in partnership with Loughborough University, the Centre for Research in Social Policy. And just as a starting point, just to set a little bit of context, this is what we mean by poverty. We mean a household living on less than 60% of average income. And we used in the course of this research, getting a little bit nerdy, but this thing called Social Metrics Commission definition. And the most important thing why we use this definition for this piece of work is it takes into account inescapable costs, including the additional costs of disability, by deducting additional support which is provided in order to cover those costs from levels of income in the household. And we got some key findings from this. So I'll talk you through the headline statistics, a little bit about how this varies by geography, some of that work we did to understand how different groups within the population are differently affected, and some really important work the team at Loughborough did around pathways into poverty at the end of life. But just to start, the headline statistics. We estimate that in 2019, more than 90,000 adults died in poverty across the UK. 90,000. I mean, and as we will see, this is not a small proportion. This is for, amongst key groups, this is a higher proportion of people facing poverty at the end of life, facing poverty, who are at the end of life compared with the wider population. And this should be an outrage. It shouldn't be acceptable that there's one person who faces dying in poverty, but there are 90,000 across our country is just, frankly, unbelievable. And these become some of the key findings broken down by group. Now, one thing is really kind of notable, is interesting. If you look at the entirety of the population, all adults, find that about 18.5% of people, they get on for 19% of people, face poverty, full stop. Adults face poverty, full stop, compared to about 16% of people at the end of life. Now, this is why it's so important to break this down by age group, because pensioners face a higher level of risk of poverty, full stop, and more of people who die are pensioners than are working age adults. So if you break it down into those two groups, it's the case that both for working age adults at the end of life, you face a considerably higher risk of poverty than if you're not at the end of life, and for pensioners, you face a higher risk of poverty at the end of life. So for both these key groups, and I particularly want to draw attention, and we will discuss this further, but amongst working age adults, for those in the last year of life, 28%, nearly 3 in 10, are living in poverty. That compares to 21% of working age adults overall. That means that your risk of facing poverty, if you are terminally ill, is about a third higher than if you are not. And as we will see further, this is in major part because, as in the case of Victor, terminal illness itself is pushing you into poverty, is pushing people into poverty. And that shouldn't be right. That shouldn't be acceptable. It'd be bad enough if we were just saying, well, you know, we'll accept the same rate of poverty amongst people who are terminally ill. You know, we've got to accept some level of poverty, so we'll accept the same rate of poverty. That's not the case. What we're accepting is people become terminally ill, their incomes are squeezed, their costs are squeezed, and they're pushed into poverty directly as a result of that, and it's not fair and it's not right. So we looked in a bit more detail at some of the variation by geography, and these give regions and nations from across the UK, and you can see there is quite a lot of variation, and these figures are for proportion of working age adults facing poverty. And you can see there's quite a lot of variation. There are some areas, particularly in London, where you've got nearly a third of working age adults living with terminal illness facing poverty. But there is no part of the country, not one of our nations, not one of our regions, where rates of poverty are not higher for working age people living with terminal illness than for those who are not. And as I mentioned, we've got the highest rate, some of those highest rates of poverty are in London, but large urban areas across the north, across the Midlands, also feature in those kind of the 20 highest rates of poverty at the end of life. In fact, this shows some of the top local authorities, the areas where poverty amongst working age people living with terminal illness are the highest. And you can see that for some of these areas, for the top 5, you've got a rate of poverty which is more than 4 in 10. More than 4 in 10 people living with terminal illness in those local authorities facing poverty. But we also wanted to understand how this issue affected different groups within the population, how this affected, whether there were differences in the risks that people faced in terms of the likelihood of facing poverty at the end of life. So we looked at gender. Now, we know that women are more likely to face poverty at the end of life than men. For pensioners, in particular, this is notable in particular, there is a considerably higher risk of poverty at the end of life for women than men. And that is almost certainly related to lower levels of pension entitlement. amongst women than men. Now, this is important in and of itself, and crucial that we're thinking about how we address that. It also speaks to the huge issue of people, full stop, not being able to get access to their state pension at the end of life, that we will speak about further later. We looked at ethnicity, and almost unbelievably, more than 40% of working age people from minority ethnic groups are estimated to face poverty at the end of life, a considerably higher proportion than amongst white people. I mean, it's 25% compared to getting on for 43%. It's wrong, it needs addressing, and we need to think about why we are tolerating such high rates of poverty amongst minority ethnic groups. And this is an interesting one. This is a really important one because it speaks again to thinking about the causes. There is significant differences amongst poverty rates at the end of life by diagnosis. And most notably, amongst working age people living with terminal illness, poverty rates amongst people dying of cancer around 21%. Poverty rates amongst people who die of other conditions, 31%. 31%, about 50% differential, 50% higher. It's astonishing. And I think it very much speaks to thinking about how do we ensure that we're creating the right pathways to support for people who are dying of illnesses other than cancer? How do we make sure that the right support, the right framework of support is provided to get people the help that they need? We also had a look at pathways into poverty. Now, I'll explain a little bit about what I mean about that. The team at Loughborough looked at the last 5 years of people's lives, and just for a little bit of explanation, they did this using longitudinal data sets, so looking at people who were responding to the same questions over time, and then at the point at which there's data which indicates the point at which they've dropped out of the data set as a result of having died. So they're able to have a look at pathways that people faced over the last 5 years of their life and split people into 4 key groups. The people who have never been in poverty, the top group, people who have, in all 5 years, never faced poverty. People who were mostly in poverty, but not every year in poverty, so 4 out of 5 years facing poverty. There's people who were moving into poverty at the end of life, people who were up to the final couple of years were not in poverty and then faced poverty as they moved towards the point of death. And then there was groups of people who moved in and out of poverty, who kind of, 1 year were not, the following year were. And they looked at the different trajectories amongst different household types. Now, they looked at different household types, including families with children. And it is, shocking. So many of these figures are just feel so wrong. They feel so wrong, but two-thirds of families with children face poverty at least once during the 5 years of life. They're also the group most likely to be in that moving into poverty group. That group of people who weren't in poverty and then following perhaps a diagnosis of terminal illness towards the end of life, they face moving into poverty. Perhaps because not only does the person living with terminal illness themselves move out of work, but perhaps their partner does as well. Perhaps they have additional costs of care as a result of having children in the household. We looked at tenure, and those in private social rented housing, particularly at risk of being in or moving into poverty, with those in social housing at the highest risk of being in the moving into poverty trajectory group. Perhaps an indication there that actually there's work to be done with social housing providers to make sure their tenants are properly supported. And this is a crucial one. This is about the predicted probability of moving into poverty at the end of life by years until death. And as you see, for each year you move towards the point of death, your risk of moving into poverty increases. Every single year you move closer to that point. And what's really important about this is it shows that terminal illness is pushing people into poverty. It is the fact of people becoming more ill, perhaps less able to work, perhaps taking on other cost pressures, that is pushing people into poverty and increasing their poverty risk. So just to summarise some of the key messages from that. So we know that poverty at the end of life is an extensive and wide-reaching issue. It affects people at all ages and in all parts of the UK. People are more likely to face poverty at the end of life than at other life stages. And I keep coming back to that because for me, that's what makes this such a crucial social justice issue. That it's not just that we're accepting that there will always be some rates of poverty amongst all groups in the population. We are accepting that if you become terminally ill, you're more likely to face poverty. You're more likely to face social disadvantage, social exclusion as a result of your income. We know that working age people are more likely to be in poverty than pensioners overall. In fact, that's why actually, as I said earlier, the risk of poverty overall is lower for people living with terminal illness, simply because a higher proportion of that group is made up of pensioners than of working age people. But the findings show that that difference between groups becomes even more pronounced for people at the end of life. And why is that? Well, we'll come on to a key reason for that in a moment. The high risk of poverty at the end of life amongst those who die in working age is likely to be both the result of people in poverty dying younger on average than those on higher incomes, and the result of people being pushed into poverty as a direct result of becoming terminally ill. When we shared the findings of this work with Michael Marmot, his response to us was, well, is this just because, is there a higher likelihood of dying in poverty because working age people are more likely to die in working age if they're living in poverty? And the answer is partly, yeah, that's true. But it's also partly that becoming terminally ill is also pushing people into poverty. And that's what that trajectory I showed a moment ago showed. And finally, people in some groups within the population who are approaching the end of life face a particularly high risk of poverty, at a time when we know people face particular vulnerability and are at least able to deal with financial hardship. So those are some of the key messages that we took away. But the question is, well, what do we do about this? Given away the answer there, there are other things as well. Well, one of the things, and we were delighted that this has happened, is in the process of happening across the UK, the changes to special rules for terminal illness, which mean that people living with terminal illness can get expedited access to their benefits, need to be implemented quickly. It would help so many people. We know it will be helping so many people to make sure they're able to get access to their benefits early on after a diagnosis of terminal illness. We need better support with energy bills for people living with terminal illness. We know that this is an incredibly current issue. We know that energy bills are absolutely soaring for everyone. But we also know that the cap on energy costs applies to average energy costs, and we know that people living with terminal illness are facing considerably higher than average energy costs. So when we talk about a cap of £2,500 on average energy costs, that may well mean for somebody living with terminal illness, who has to keep the heating a bit higher, who has to power medical equipment, it could be £5,000, the bill that they face. We need better targeted support for that group. And I'm delighted, actually, last week, a private member's bill from Alex Cunningham MP was heard in the House of Commons, which would have extended key forms of support with energy costs to more people living with terminal illness. And we're really hopeful. We had a very positive response from the Minister, and really hopeful can continue to get engagement on that issue and get some more targeted support with energy bills for people living with terminal illness in the future. However, there is a third thing. And this, I mean, when it comes to support for people living with terminal illness in working age, who are unlucky enough to become terminally ill in working age, this more than anything is the key to reducing those outrageous poverty rates, extending the state pension. At the moment, if you're unlucky enough to become terminally ill in working age, not only have you faced a profound unfairness in your life through the becoming ill itself, but you face a double unfairness that you can't access your state pension. For many people, they're paid in for many years. In fact, as you can see on the final point in this page, analysis again from Loughborough University shows that on average, working age people living with terminal illness have paid more than 23 years of national insurance contributions, paid nearly enough for a full state pension in and of its own right. But what will you get? Absolutely nothing. Absolutely. It's like the reverse of an insurance principle. You're unlucky enough to become ill, you don't get anything. It's wrong, and it needs to change. It would be the single greatest measure that could prevent poverty at the end of life. We know that. We know it would lift around 8,600 dying people out of poverty each year. It would reduce poverty rates amongst people, working age people living with terminal illness, to about the same as amongst working age people, full stop. And perhaps most significantly, it would cost around £114 million. Now, that might sound like a lot of money. I mean, I've worked in benefits for a long time. I promise you can't buy anything for £114 million. It's 0.1% of the overall state pension bill it would cost to extend the state pension to working age people living with terminal illness. So, I wanted to share, before I conclude, just 3 concluding thoughts from this. Firstly, this is urgent, and it affects an awful lot of people. And in some ways, the urgency is undeniable. The fact that it affects an awful lot of people is the part that I feel just doesn't sometimes get through. It doesn't get through to the decision makers, because I think it's almost like people can't really believe that if you face terminal illness, you could also face poverty. There's almost the kind of sense that, no, you just can't process that. But for people living, like Victor, living in his car, the reality is really all too real. And the truth is, it's not just 1 or 2 people, it's thousands and thousands and thousands, tens of thousands of people living right now, living with terminal illness, living in poverty. Secondly, this is all our business. This is all our business. I may have given the impression it's not by saying the answer is the state pension, but I promise there are things you can do as well. There is a role for every single one of us in this room in better supporting people facing poverty at the end of life. It might be making sure that they get access to the special rules. It might be helping to complete a form. It might be putting in decent evidence and supporting someone to complete decent evidence for a disability benefit claim. It might be something like poverty-proofing hospice care, making sure that the experience of being supported within communities or within hospices isn't affected by the fact of living in poverty. It may be improving access to care and support for people living with terminal illness. There is no shortage of things you can do. And if you think you can't do anything, come and have a chat with me afterwards. I'll find you something to do, I promise. So this is all our business. And finally, and this is the thought I want to conclude on, we wouldn't run a hospice where you couldn't turn the heating on, where you couldn't provide decent food. We wouldn't. We'd shut ourselves down. We'd be shut down if we weren't shutting ourselves down. We wouldn't do it in our hospices, and yet we tolerate it. We tolerate the fact that dying people are facing these conditions at home. We shouldn't, and I hope I've started to just make a little bit of a case today that we need to work together in order to address this challenge. Thank you.
Sam, thank you very much. I'm just looking through the questions. So the most popular question is from Sharon, which is, what is the most effective thing hospices and national organisations like Hospice UK, Curie, etc. can do to work locally and nationally to change the shocking situation being described to us? Should we also be looking to partner on this with others such as Citizens Advice, Age UK, etc.?
Yeah, absolutely. I'm curious, incidentally, about this taking most popular question by algorithm. Makes me slightly nervous. But it's a great question. It's a great question. And I had a conversation the other week. It came out of a different conference, actually. I had a conversation last week with somebody from an organisation called Children North East, who's doing some work around poverty-proofing hospice care. Now, for people who aren't aware, the process of poverty-proofing is where you look at a system and you think about how might that system be experienced from the perspective of someone living in poverty. And it started with schools, and Children North East have been a brilliant organisation leading work with schools around this. Looking at the school day and thinking about, well, you know, if you were a young person living in poverty, what aspects of our system would make the day work less well from your perspective? So it might be things like, you know, I can't afford a school uniform, so we need to review our school uniform policies to make sure they're affordable. It might be about school meals, and if you're on free school meals, being kind of easily identifiable and feeling stigmatized as a result of that. And we're having a chat, and I know that they're doing some work looking at poverty-proofing in the end-of-life care system, and I think there's really important work that could be done there to think through the services we provide from the perspective of people living in poverty and thinking, you know, is there different ways in which we could provide these services which would respond to the circumstances that they face? And I think, and I indicate this, and the very final point that I made, this problem has become all the more pressing because more people are dying at home. And this isn't, I mean, we know that this has been true through the pandemic, but actually we know it's been true getting on for a generation now, a higher proportion of people facing the end of their life at home. And in some respects, that's a really good thing. We know there are more people who want to die at home than get to, but it does create this new challenge of making sure the support that people receive in their home is right And I think that the big challenge right now is making sure that actually how do we respond to thinking through working with other colleague organisations, working with people living with terminal illness themselves to think through what does the home situation need to look like in order to make sure they're not facing kind of disadvantage.
Thank you. So the next most popular question from Emma, extending the state pension, when you say it's 0.1% of the total bill and would only cost
114 million.
114 million.
Cheap as chips.
So you'll have done your analysis with your policy and advocacy team. Why isn't it happening?
Why isn't it happening? Well, I mean, we've only just recommended it. We only recommended it this summer. There is a lot of groundwork still to be done. We shouldn't deny, I say 114 million is cheap. It is cheap in the scheme of things, but it's still a lot of money. We need to work with the government to make the case. And, you know, we've had sympathetic understanding responses from the government, but we know, you know, there are considerable pressures on budgets at the moment. We're going to need to continue and build that case. But the more we can work with colleagues to make sure that case is heard, to make sure that both the government and the opposition and national governments across the UK hear this case, hear that this is a social justice issue, the more likely it is that we're going to get this in the future.
Thank you. Well, that's something hopefully we can all support as well with our discussions with MPs and so on. So a question from Mark. This one's about collaboration within the end-of-life sector. Marie Curie has done amazing work highlighting inequalities and poverty and influencing the sector's agenda more than any other organisation. However, in effecting change with communities, why are you not engaging more with independent hospices to increase collective impact, reduce duplication and competition? So, nice, easy question for you.
Oh, my goodness.
From the floor.
I'd love to. I'd love to is the answer. If there are independent hospices there, come and have a chat with me about what we can do together. I would love to work with as many partners as possible in order to build the case for change. And as I say, you know, this isn't just about building the case for change within, you know, complex national policy systems. This is about making the case for change locally as well, within things which are within your control, within your remit, things that can just be done and acted on in a different way.
Thank you. So the next question about children's palliative care from Christine. Do you have any data around poverty of parents who have a child with a life-limiting or life-threatening illness? My experience would be parents are usually working age, have children, and are from minorities, so higher risk. Is there any data around families recovering from this poverty following the death of the loss of their child?
Sadly, no. The data is much less good for children living with terminal illness, simply because normally these data sets are only, the surveys themselves are only responded to by adults. I'll have a chat actually with the Loughborough team about whether there is anything we could do, because it is a really important issue. But I'd draw attention to, I suspect many of the issues overlap with those I highlighted earlier amongst families with children where a parent faces terminal illness. And as I said, 2/3 of families with children where a parent is living with terminal illness facing poverty in the final 5 years of life is frankly unacceptable. I suspect many of the challenges, both parents and partners leaving work, are similar for families caring for a child living with terminal illness as well, but it's definitely one I'll take away.
And we'll know from work done by children's hospices and also by Together for Short Lives that a particular challenge facing children with life-limiting conditions tends to be the very high energy usage at home.
Yeah.
For all of the medical and mobility equipment that the child needs. And the benefit has by no means caught up, has it? There is a benefit for that, but it hasn't caught up, is my understanding, with the energy prices?
Well, there is some support. There is some support available. There are questions as to whether and how energy support with medical equipment is provided, and some forms of equipment often not being covered, late payments being made. There are some big issues around that. Actually, I was delighted that Marie Curie were able to sign a letter jointly with Together for Short Lives, Hospice UK and Sue Ryder just last week to BEIS to make the case both for addressing energy costs this winter, but also energy sustainability in the case of planned blackouts and so forth.
A question from Jackie. So if you have 96,000 people in poverty, and the changes that we were discussing to the state pension would only help 9,000, what specific changes would you advocate to help reach the other almost 90,000 there? What
a very good question. Well, we do advocate for additional changes. There is no, I should say, though the state pension change only, of course, supports people living with working age, living with terminal illness. We focused on that group with that call because we know the rates of poverty amongst that group are so shockingly high. But that is, of course, I think it's about 28,000 of the 90,000 people who die in poverty are people who die in working age, just because most people who die are pensioners. So there was a reason for choosing that, but it's no silver bullet. There is no one solution to this problem, and things like additional support with energy costs that we have talked about. Things like additional support we've talked about. We make the case in the report for additional support with childcare costs for families with children in order to target that group. And crucially, I think, a big part of this is actually practice change as well. And I come back to this, making sure for pensioners, for example, they're taking up pension credit, which is a means-tested benefit which can provide additional support above and beyond the state pension. Things like that can be a critical measures in order to alleviate poverty amongst older people.
Thanks, Sam. The next two questions are going to focus, I suppose, more on asking you an opinion about how the hospice sector can challenge itself to do better. One from Catherine: the disparities for those from families from ethnic minority groups is shocking. How can the hospice sector realistically address this, given that our data shows that we are already struggling to reach out to these groups effectively ourselves?
I think it's an incredibly important point, and the figures were, more than 40%, 42%, I think, of working age adults living with terminal illness from a minority ethnic group facing poverty at the end of life is just wrong. I go back to actually some of this kind of this focus on practice change. I think that there are many things that can be done to review how services are organised in a way which responds to the needs of different groups, including people from minority ethnic groups. For example, I mentioned a moment ago take-up of benefits. Making sure that materials are translated into a range of languages, that materials are shared and people are supported in order to be able to engage with them and to work with people in order to claim the entitlements that are available would be a big step forward. But I don't have all the answers to this. It's a really complex problem, and actually I think that there is systems level work that needs to happen to recognise some of the intersections between ethnicity and poverty, and to address why it is that the two go together so often, and to make sure that we're engaging with it and addressing it and putting in place both the policy and practice responses to alleviate it.
Thank you. And then the second challenge, I suppose, to the sector directly comes from Nigel, who asks, surely all hospices should focus their wealth and their resources more on supporting real care at home, rather than in buildings where we continue on average to offer so much to so few.
It's a really good point. I think that certainly, I mean, there has been, of course, a trend towards more care being provided at home. So I think some of that transition is happening over time. I think that the question, or a big question, is how do we get it right? How do we make sure that those services are in community settings are provided in the right way? And it doesn't necessarily mean taking it on all ourselves as palliative and end-of-life care providers. I think that there is a big question of working with local and national systems in order to provide joined-up responses. So, for example, I mentioned the high levels of poverty facing social tenants. I think there's important work to be done with social housing providers to make sure they're playing their role in providing the right support for their tenants. I think there's important work to be done with local authorities around the care and support that they can provide, not least with energy bills. So I think there is it's right to emphasise that need for focus on improving community support in community settings. I think that there are important stakeholders that we can work with, that we can engage with, in order to do things better for the future.
Do you think, Sam, just thinking aloud, I remember earlier in the summer, I think, just the onset of the cost of living crisis when energy prices were first really rocketing, the charity Sense announced that it was making for the first time unconditional cash transfers to families of certain categories of children registered with them. I think Together for Short Lives is also expanding its butterfly grant program. Would that be something that you think that independent hospices might consider, so that if there is a patient who the family team, for example, think may be struggling economically and maybe in that living in poverty or close to living in poverty cohort, that a local hospice could say, well, in addition to this support in your home, we'd like to give you a £500 cash grant to help with heating and any other practical costs. And if we got into that sort of service delivery, what would the exit strategy be? Could you ever get out, do you think?
Oh, that's an interesting question. Well, let me deal with the question of whether we should get in for about getting out again. But I think there is certainly a case for it. I think it needs to be thought through carefully. I think in doing so, in particular, it's really important to coordinate with those who, with other organisations that are providing similar services, to make sure that, the overlap is and duplication is limited, and it's reaching those who most need the support. I think that there is a big question around that, about making sure, and we talked about underserved communities a moment ago. If you were doing that, how do you make sure that those who need the support the most, particularly those who may have been underserved in the past, are being supported through it, and you're managing to get the support to those who really do need it the most. The other point I'd make about it is it's only part of the solution. I mean, you look at the social security system provides cash support of more than £100 billion. In that kind of context, the amount of support that's going to be able to be provided through cash grants through charitable organisations that can be important, well-targeted provision is only going to be part of the solution. It's about getting on, I think, for about £20 billion a year that doesn't get claimed in benefits. So I think there's also a really important role in actually, we do need to get more cash into people's pockets. Can we support people to make sure that they are claiming the benefits that they're entitled to? And that's not just a job for, though it is an important job for people, social workers, benefit advisors, others. clinicians also have an important role in it, because it's so, getting that support is so based on the evidence that is put in.
Yeah, excellent idea. Especially for those of us who worked in international development, that's one of the main interventions that sort of charities like Save the Children or CARE or Oxfam do in middle-income countries, where there is a kind of welfare provision, but it's very hard to navigate. So it's interesting to see that some of those strategies may need to be insourced, if you like, in terms of helping people in poverty in the UK. So I'm going to link two questions, one from Michael and one from Helen, which is around people's experience of, Helen and Libby, people's experience of an understanding of poverty. So Helen asks, what is the understanding of poverty amongst those who've been bereaved, particularly for those who've been full-time family carers, e.g. when the associated benefits stop and recovery time is needed? And Libby also asks, what do you think is the effect of poverty on palliative and end-of-life care experience from the perspective of the service user, which is what we were talking about before the session a bit. Yeah.
Well, those if we can take those slightly separately, the issue around poverty amongst people who have been bereaved is really profound. You mentioned kindly in the introduction that Marie Curie had been involved in establishing the UK Commission on Bereavement, looking at how bereaved people are supported across the UK. And a big issue that came up time and time again was people facing financial exclusion following a bereavement, not being kind of ready to move back into work, perhaps having additional caring responsibilities following a bereavement. But for a number of reasons, poverty for people who have faced bereavement can be really severe, and the support that is provided, where there is support provided, it can end very quickly. So, for example, carer's allowance, which will be provided to people while they're a carer, ends just two months or so following a bereavement. Now, one of the calls of the UK Commission on Bereavement, for example, was for that to be extended from 2 months to 6 months, so that people have a longer window following a bereavement in order to have that consistency of income. But it's a really important issue. And big issues, incidentally, not just with cash support, but also going back to issues facing social tenants and actually private sector tenants as well. A lot of cases come up time and again since we published the report, actually, of social housing providers evicting people who have been bereaved because they weren't the tenant, because the person who died was the tenant, they weren't on the tenancy agreement. Heard one case of a young man who was evicted just a couple of weeks after the death of his father. And it's so, again, just so tied up with issues of poverty, issues of social exclusion. We need to deal with that. On the question of palliative care, it brings us right back to the issue. I mean, firstly, poverty, for me, poverty is part of palliative care. I mean, when Cicely Saunders talked about the kind of holistic pain, I think she was thinking about, all of the different forms of suffering that people can go through at the end of life. And the role of palliative care is to address them all. And that must include ensuring that people have the financial support that they need. But there is also a very direct case for health systems, let me put it that way, that if people face poverty, it is going to make pressures on health services worse. We know that there are profound health impacts for people if they're living in a cold home. We know that there are profound health impacts if people aren't getting the right food. We know, obviously, there are profound health impacts if people aren't able to power their medical equipment. So this has a direct implication for health service provision as well. But I would very strongly emphasise that is not the only reason to be dealing with this problem.
Mary, I think this is great, suggests reaching out to Martin Lewis, who obviously has a very platform that he's earned with a lot of hard work in terms of speaking out for people on cost of living. Should we be reaching out to him, given his ability to access not just the general public but also politicians? Perhaps he could help palliative care charities focus on this question.
I think that's a great example. I'd love to make the case to him about the state pension extension in particular. If anyone's got his phone number, do just let me know. I'll give him a ring.
We'll just put it up on the main screen behind. I'm sure GDPR would be fine with that. Yeah. So many good questions. Thank you, everybody, for putting them in. I've only got 3 minutes left of the session, so I'm going to I think ask a last question, which is from Debbie. Is the current cost of living crisis, you've got your own research, you know that Hospice UK also published some research about the numbers of people dying at home during the COVID pandemic. Do you believe that the current cost of living crisis is likely to push more people back towards dying in hospitals or hospices rather than their preference to die at home? And if so, how might we as a sector face the challenge of enhanced demand for inpatient services, because many hospices have been gradually moving away from inpatient towards more community, balancing it with community-based services?
That's a really interesting question. I mean, it could. It certainly could. But how ridiculous would it be if we're paying for hospital beds at the outrageous, enormous cost that hospital beds do cost, because we're not willing to pay the much smaller amounts of money that are needed for people to be properly supported at home, for people to be able to keep the heating on at home. If people are going into hospital, not because they absolutely need to be in hospital, but because they can't turn the power on, that's not a good use of care. So, yeah, I mean, that could be an outcome of it. I think it would be very wrong if it was.
Good. Well, lots of really great questions, and thank you very much. Is there any closing rallying cry you'd like to give to the hospice sector in terms of how we can support this campaign and this policy agenda?
Oh my goodness. Well, if people haven't gone on the website already to sign the campaign to extend the state pension and other forms of support to people with terminal illness, do go to the Marie Curie website and sign. We've got 150,000 signatures now onto that campaign. But if anyone wants a kind of conversation about kind of what more your hospice or how we can work together more generally in order to support people facing poverty at the end of life, do have a chat. As said earlier, really, really want to work with as many people as possible to make this case for the future.
Good. Well, the last thing for me to do is to thank Sam very much on behalf of everybody here for being with us today. Thank you very much.